Today, I'm going to give you an overview about the things I'm hopeful to be able to do for the next, let's say, 10 years in University of Minnesota. I'm hopeful that I will be able to kind of learn from different people who have been doing these studies for quite a long time. So before getting started, I would like to thank all my previous mentors, especially Martin Paulus, who was supporting me for quite a long time. He was my postdoc supervisor, and many other supervisors they had during the last couple of years in my medical school, in my PhD, and during my postdoc and afterwards. So I really appreciate their support. And without their support, it was impossible for me to be here and present what I'm presenting today. And I'm also kind of really thankful for all the colleagues and kind of faculty members here that I had this opportunity to meet them so far. And I've been enjoying discussing with them. Today I was discussing with Dr. Matt Kushner about the things that we are doing, and he was asking lots of really kind of serious questions about fMRI and kind of the skeptics that we have about fMRI. So I'm really enjoying this discussion. I'm looking forward to kind of sit together with Mark Thomas and David Redditch and others to be able to see how we can move forward and do things together. I had another meeting with Scott also we discussed about different things. So I'm really hopeful to be able to kind of learn from different people here in the community. So let's just start from this issue that when we talk about drug addiction, people who are in the room, they are experts in the field of drug addiction. So I'm not going to talk about basics. So we know that when we talk about drug addiction, we are talking about many different aspects. We know different neurocircuits are involved in drug addiction, starting from executive circuits, salient circuits, self-directed processing circuits, things related to memory processing, habit circuits, and things related to gain and loss. So when we know that many different circuits are involved in drug addiction, and we always have this question in terms of how we can engage these circuits in a meaningful way in our studies with drug addiction, and see how we might be able to kind of reasonably record what is happening in these circuits in the brain. Over the time, people realize that when we expose people to drug-related cues and put them in the context that they have been using drugs, that cue exposure paradigm could be a kind of a good or meaningful kind of paradigm to be able to activate those circuits. So based on the systematic reviews and meta-analysis that people have done, including one that Anna has done, one of the faculty members here in the University of Minnesota, it seems that kind of these paradigms, cue exposure paradigms, are quite helpful in terms of engaging those networks. And that is what I'm really interested to in terms of exploring those types of paradigms. For being able to use cue-based activation in fMRI, we need to have a set of drug cues that we also, as you can see here, we need to have drug-related cues, and also we need to have control cues. As you can see here, even in this setting, we have a set of opioid-related cues here, and we have a set of control cues. And as you can see, we need to control for many aspects of these cues to be able to use them in an fMRI study, because we need to control for different psychophysics features and also different psychological features of these cues to be able to use them for designing a good fMRI task to engage those networks and activate those networks. For being able to do that, we have recently put together a large database of 360 images from kind of different contexts, with control images, met images, and opioid-related images. And we have done quite an extensive study in terms of their psychophysics features, psychological features, arousal, craving. And based on that, we published a recent paper, which is basically the first validated met and opioid cue database that is right now outside and people can use. And we provided all the entire database right now online, so people can just download the database and use the database. And using this database, we have been successful in basically develop different sorts of fMRI tasks. For example, this one, as you can see here, we have images or sets of images that we have control images, opioid-related images, and met-related images, that all of them are equivalent in terms of their psychophysics features. And also the tasks that we have with opioid and met they are also kind of equivalent in terms of the valence and arousal and craving that they can make. So we control all those contexts. So we can have tasks that even could be used in MET users or opioid users, and then we can compare the results in two different contexts. And then we have been able to develop different sets of tasks that they still are equivalent to each other, but they are not identical. So we have, at least here, we have 3 sets of fMRI tasks that could give us this opportunity to be able to do repeated measurements without using identical images in the database. So we have been trying to enhance the quality of studies that we are doing in this field. And of course, then we use these databases and these fMRI tasks, we have activations in different parts of the brain. So we have activations in different networks that we have been discussing. So we can show the activations in different parts of the brain. And even if I show you the activations in terms of different brainstem regions in a kind of brainstem atlas, you can see that, of course, areas in the subcortical areas are involved, or specific areas in the frontal cortex, or different areas of the brain could be engaged with this fMRI task that I showed you before. And meanwhile, other than just kind of doing one study, we have been able to do multiple studies in terms of kind of having a discovery sample and then have replication samples to see, okay, if we change the clinical context, if we change the type of clinical population that we have, can we still have the same results? So how much the results would be replicable in different settings? And even trying to see how, if we repeat the same kind of the assessments in the same population, in the retest, do we have the same results or not? And what are the areas that would be responding the same, or what are the areas that would not be doing the same? And of course, kind of measuring the ICC in terms of how is the reliability. And ICC is a major challenge right now in the field of fMRI, because we know that there are many fMRI tests, they have a really low ICC values. And even going to the details of ICC in terms of which ICC would be the right measure, and there are many discussions about that. I'm not going to go to the details about that. But the good thing about the task, the drug cue reactivity task, and it is not only from our lab, there are a few other labs that they replicated that with food cue reactivity tasks. It seems that they have, at least in some areas in the brain, we have some like good level of ICC. For example, this one, we have a threshold of 0.5, as you can see, especially areas like inferior frontal gyrus, as you can see here, and some other areas in the frontal areas, we have a reasonable ICC in repeated testing. So it seems that we have a reasonable level of data. And it's always a question in terms of, even we want to use these measures, especially as outcome measure for trials, how much reliability we have. So this is another ongoing discussion. We are still working, and we are increasing the size of these databases to be able to discuss more about the reliability of these measures that we are putting together. Meanwhile, we have always been interested to see how we can even develop a specific checklist and quality control measures in the field to make sure that we can increase the transparency of what people are doing. So we have recently developed a checklist for studies that are going to report any drug cue activity studies to make sure that they are reporting all the details that are necessary for reporting a drug cue reactivity study. And this has been recently accepted in Nature protocol, and it will be published there hopefully soon. So going back to kind of the circuits that we have been discussing. Okay, now we are in a level that, okay, we have a measure that could kind of measure the engagement of these networks. Then the next question would be, is there any way that we can modulate these circuits? Is there any intervention that could be helpful to modulate these circuits? And that is the second part of my talk. I'm trying to give you an idea about, okay, now we have a measurement. Is there any way that we can develop interventions to use these measurements before and after these interventions, and see how we can engage those networks and modulate those networks? In this context, we have recently developed a new paradigm specifically for cue-based interventions, cognitive intervention based on cue databases. People in the field of kind of drug cue reactivity, they have done lots of drug cue exposure studies, and drug cue exposure studies have not been very successful so far. So in a new sort of paradigm, we try to combine different paradigms together. So we try to combine queue extinction-based interventions, the memory consolidation, and also future episodic thinking. So we try to combine these three different kind of types of interventions and develop a new specific cognitive interventions based on the cues. And I'm not going to go to the details. If people are interested, I definitely would be happy to give more details about the details of the paradigm and how we are putting together a specific kind of intervention using these kind of interventions. But the main core of this intervention is the drug cues that I showed you before. In terms of those kind of validated drug cues, we are using them as a way to kind of reactivate memories, reshape those memories, and reconsolidate kind of memories that are being reshaped based on interventions that we are making for their episodic future thinking. The other way that we can potentially modulate those networks are non-invasive brain stimulation intervention, and people are doing different versions of these non-invasive brain stimulation interventions. So I'm going to give you a few ideas about what we have done so far and what we are going to do in U of M for the next couple of years, hopefully with the support and help from others. I'm going to stop here for a few seconds. If there is a specific question or something that people are interested to talk about, I would be happy. As Mark has mentioned, I really like to make it more interactive. So any specific thought, anything that people are interested to discuss? Okay, so it seems that there's no question. So let me just move forward.
I wouldn't mind hearing a little more about the intervention on the last slide that you had.
Absolutely, yeah. I definitely would be happy to go for a little bit more details about that. The idea that we have, we know that when we expose people to drug-related cues, they can activate memories related to drugs. Most of these drug-related cues are highly relevant to the context that people have been using drugs, especially when we give them different options in terms of different varieties of these cues. And I've tried that with different clinical settings, and most of the time they activate lots of memories. Even if they do not have a specific kind of memory with that specific context, they can activate some other relevant memories. So we know that when we expose people to drug-related cues, we have lots of memory activations. So this is the case. We know that is the case. And we know that those memories would probably be liable for a few minutes up to an hour. So we are bringing them to a level that we can modulate them. But how we might be able to modulate those memories? One of the things that we kind of recently developed is a package for discussing about those memories in the context of EFT. So we start to kind of discuss about the details in terms of, okay, what would be happening when you are exposed to this drug cue? What are the strategies that you can do if you are going to use drug, or if you are going to prevent your kind of drug use behavior? What are the predictions that you have from those behaviors? Then people can start to develop different intentions in terms of, okay, if I'm in this specific scenario, I'm gonna kind of develop these sort of kind of intentions to make when I'm facing this specific scenario, and then start to make plans. So we have a structured, manualized kind of workbook that we work with people in terms of putting together those simulations, predictions, intentions, and plans that people make about those specific memories. And we try to help them to reshape the memories that they have within the context of that kind of episodic future thinking kind of process that we make them with them. And then we try to wrap up the session. And then we come back the next session and we discuss about those things that we have. So we try to kind of reshape those memories and attach them with the kind of the package that we have with episodic future thinking, and try to see how we can kind of shape the memories in a way that we are interested to do. And in some pilot things that we have done so far, the result is really amazing. First of all, it's really engaging. In my first experiences, people discuss about, even most of the time we kind of need to even kind of stay for a longer period of time to be able to wrap up the session, because people are really engaged and discuss about different things that they can do and different strategies. And it seems simple in the first view, but there are lots of minor details in terms of how to kind of reshape those memories. But that's the basic idea of being able not to just do Q exposure in the context of just thinking, okay, if we expose them, there would be a habituation and there would be an extinction. But also kind of adding specific content to those memories, the content that would be. And we have already started discussion with few other colleagues in terms of, okay, if we can boost that kind of memory reshaping with some other interventions. So there are studies right now in terms of potentials for even using specific medications, things like propranolol, the other things that could also be involved in this process of kind of the re-experiencing that people do, and also some other ideas for doing some non-invasive brain stimulation interventions while people are kind of reshaping those memories. So there are definitely interesting potentials for that. And I mean, I was discussing with Warren Bickel, who is one of the authors of this kind of work. When I was doing that in the clinical work, I was thinking that that's a good idea. I mean, we can discuss, because what Warren is doing, I received an email from David Reddish about that in terms of, it is different with the model that Warren Bickel is doing. I mean, what Warren is doing is not really very kind of Q-based interventions. They are doing different things regarding EFT. I think, and Warren was thinking that's a cool idea that we can kind of discuss. So we have already started to discuss about how to go for the details, and I would definitely be happy. That would be something like, I would be happy to bring something like a 1-hour talk in terms of the details of how we try to reshape those memories, and what are the things that we do for the exposure, and what are the things that we do not do. So there are definitely lots of minor details about that as well.
So let me follow up on what Mark was at on this discussion you're having, because Warren is convinced that his episodic future thinking data is changing discounting. I'm convinced that what he's doing is enhancing deliberative control. But it sounds to me like you're actually trying to connect up the cues that most people talk about in Pavlovian terms into a deliberative structure.
Exactly. That's exactly the case, right? So what I mean, I'm really kind of interested to what Warren is doing in terms of whether extending the future time horizon, or is just increasing the deliberate control that people have, or a combination of both. But I think that the good thing about this is, I mean, it gives a context in a way that I think is more engaging, especially for substance users, and they feel that is more relevant to what they are facing. At least in my, we haven't tested that. We are still kind of discussing about kind of putting together something like an our UG3, UH3 grant to see if we can engage those networks. But we are still kind of, I think that there are definitely interesting clinical kind of issues for that. And I've not seen anybody has done things like this before.
Have you looked at the neural circuits that are involved during this process?
That is the question that we have in terms of, okay, so we have fMRI measures, we have the paradigm, so let's do them together. So that's the reason I'm here, trying to convince kind of senior figures like you and Mark and others to support this idea.
It's a very interesting idea.
It sure is.
For non-invasive brain stimulation side, in terms of how we might be able to kind of engage those neural circuits, and how we might be able to kind of see if we can do some direct interventions in the same context. So I've been really interested to transcranial electrical stimulation because of many reasons. One of the reasons I'm really interested about transcranial electrical stimulation is that this kind of setting is really scalable. So we can give people kind of really simple headsets, and they can have that in home. And if it is effective, we can have this kind of stimulation, something like 5 a.m. in the morning or 2 a.m. in the morning, when there is no sponsor or any consultant available or counselor available, when they are facing drug craving out of blue. And I mean, those who work with drug users, they know that there are, even if you can kind of suppress the drug craving for 20-30% for a few minutes, when they are in the kind of the peak of the level of craving that they have 3 a.m. in the morning, that would be saving lives. So I realized that even kind of if we can make a small change that is going to be really helpful. But the question I still have is if there is any effect of what we are doing with transcranial stimulation. So we are still kind of really skeptical about what we are doing, but trying to see how we can move forward for that. Like many others, I mean, we have done the first basically assessments for drug for methamphetamine craving in terms of if we can do transcranial direct current stimulation, can we change the drug craving? We show that we can modulate the drug craving. The level of craving could be reduced with the stimulation that we have been doing. It was quite kind of a small study, but there are some meta-analysis in terms of it seems that based on the published so far, we might be able to modulate drug craving. I'm still skeptical, but we are seeing that there is an effect with meta-analysis that we are doing. But how does it work? How we make any change in those neural circuits? What are the things that people are doing that? For that, we have done another study with fMRI in a crossover design, just 15 subjects, a really small study with the same kind of stimulation protocol, trying to see, okay, if we modulate dorsolateral prefrontal cortex, can we change top-down regulation in terms of frontal kind of limbic structures? Can we change those kind of top-down regulation? And we have been interested to anterior cingulate cortex, kind of insular cortex, amygdala, and ventral striatum. So we have interest to see if we can modulate those connectivities. And in the same context, I mean, we have been able to show that yes, with the kind of stimulation on the right side, we can have increased connectivity with kind of the right side anterior insular cortex, and also with cathodal, which basically is supposed to decrease the excitability. There are still kind of skepticism about that, but that could reduce the connectivity with anterior cingulate cortex in both sides. And it seems that we also have some kind of reduction in connectivity with the anterior cingulate cortex, anterior cingulate cortex as well, and the dorsal part of the. So insular cortex and cingulate cortex are going to be, and so it's mainly something like fronto-opercular circuit that is engaged.
So Hamid, I think I missed something there. So when you're talking about connectivity in this context, you're talking about what
we are talking about? We are talking about psychophysiological interaction. So we are talking about task-based connectivity. So connectivity in the context of drug cue reactivity.
Okay.
So it is kind of enhanced connectivity regarding the specific task structure that we have in kind of the psychophysiological, what we call psychophysiological interaction analysis. So it is a PPI analysis.
Okay.
But in terms of just resting, we have done that in resting state data as well, in terms of if we can modulate the relationship between default mode network and control network, and what we call saliency network, which is mainly frontal singulo-opercular network, the saliency network. We have been able to show that kind of with the stimulation, we can change the directions from default mode network to executive control network and salience network. So we can engage both of these networks in a higher level when we do the resting state. Even in the resting state, it is kind of obvious that we can. It's, I shouldn't say obvious. It just there is a kind of a significant effect in the small size sample that we have here. But we have been thinking, because we mainly had kind of changes in singulo-opercular network, we have been thinking about frontoparietal network, if we can do more targeted interventions in terms of engaging frontoparietal network, and see if we do what we call frontoparietal synchronization, FPS. We synchronize alternating current stimulation in two sides in frontoparietal, and trying to engage this specific network with this frontoparietal synchronization. We are already doing frontoparietal synchronization with opioid user. I'm running that in Oklahoma right now. We had an issue with one of the subjects. I was not trying to solve that before the meeting, so I was discussing with different people too. So I'm still kind of trying to finish that trial in Oklahoma. We are still recruiting subjects with all these COVID situations, which really makes things really complex. But we have been kind of trying to push that kind of trial forward to see what we have in terms of the results. But even doing that trial, I realized that it is not as easy as I was thinking in the first place in terms of engaging frontoparietal network. And I started to realize that when we talk about frontoparietal network, we talk about 100 different things at the same time. We do not have one single frontoparietal network. There are different versions. And then I realized that even the arrangement of the electrodes that we are making is going to be complex in terms of what we did the best frontoparietal network that we are looking for. So we have done another full study in details about what we did the better frontoparietal network to engage in the Curie activity setting. So this is another full discussion. We already have that under review with brain stimulation, and we have two kind of critical reviewers, and we are discussing with them in terms of we can get that published. So we are working on that. Meanwhile, I recently kind of finalized a larger trial with 60 subjects with Matthews disorder, with the fMRI and the transcranial current stimulation. One of the first things that is obvious to me is, I mean, this is the head modeling of the level of current that these 60 subjects are receiving. Obviously, we have a huge level of variation between subjects in terms of the level of current they're receiving. And because we put just two electrodes, large electrodes over the head, and we just deliver the current, and people have different skull sizes, different skull thickness, whatever. I mean, brains are different. And even as you can see here, the shapes of the brain are different. So the level of current that they actually, so there are patients that they receive lots of currents. There are patients that they do not receive that much current. So obviously there is a significant level of difference between subjects that we have. And that is one of the sources of variations, and that could make things really complex. We have published another paper in scientific reports about that level of variation, not only for our montage, but from other montages in DLPFC. That's a kind of ongoing discussion in terms of how we are going to deal with that. So to be able to manage that, what I'm trying to do, I'm trying to combine the electrical stimulation with fMRI to be able to record what I'm doing, and trying to have a better idea about what I'm actually doing inside the kind of the scanner, and what are the things that I'm stimulating. In this context, I've started to kind of go for more details in terms of how I can integrate transcranial direct current stimulation with fMRI. So we try to develop kind of more kind of sophistication for that. We have recently put another consensus statement, which is also accepted in Nature protocols, which we call contest checklist. It is about doing electrical stimulation inside the scanner while we are recording fMRI, which is quite unique because those people who are doing non-invasive brain stimulation, they know it's really hard to do brain stimulation while you are doing brain mapping. Probably the other area that is a little bit ahead of what we are doing is the combination of EEG TMS, that I know that Alec Bridge and others are doing that. But combination of EEG TMS, I mean, there are advantages for EEG kind of TMS, but it's really hard to do TMS inside the fMRI scanner. There are labs that are doing TMS inside the scanner, but there are many challenges, and it's really hard to find people that they have published multiple TMS fMRI studies, because when you do one, you just say, okay, that's enough. I would not do the second one. So it's really complex to do. But I realized that specifically with transcranial electrical stimulation, there are way more potentials in combining transcranial electrical stimulation with fMRI because of some technical reasons. And I can discuss about those technical reasons. Because of some technical reasons, we can bring electrical stimulation to the scanner, and we can manage the level of noise. And I was skeptical. My kind of MR physicist was even more skeptical. I mean, we have been all really skeptical that we can make that happen. But we have started to work on that and try to see, okay, how we might be able to make that happen. So we try to kind of go for all the details that are important in terms of how to do the stimulation inside the scanner. So we put kind of different technical details about that, and we discuss about that with different teams around the world. We basically brought together everyone who is doing TES fMRI together to make a consensus in terms of what will be the power sequence, what are the technical details, what you are doing in the lab in Germany, what are you doing in China, how people are doing. So we try to kind of put all those things together and made a consensus about what is the best practice for that. The good thing about this setting is what we can do. We can measure, for example, frontoparietal inside the scanner while we are doing frontoparietal stimulation. And in this context, then what we can do, we can basically define an optimization space in terms of, okay, I'm interested to increase the level of connectivity between frontoparietal area. We're just going to this specific frequency band and try different frequencies to see which frequency would be able to engage these networks together in a most efficient way. And even trying to use different phase delays between these nodes. So something like 5 degrees, one node ahead of the other node, 10 degrees, 15 degrees. So in terms of the oscillation, how we can even put one node ahead of the other node and try to see if we can consider the directionality between nodes in terms of how to kind of synchronize these nodes together. That is the kind of the promise of being able to do that inside the scanner. And we call that closed loop TS fMRI.
Hamid, this is really super interesting here. So I have a question. And this may be a naive question, or it may not make any sense at all, but if you do this inside the scanner and then you are able to optimize the electrical stimulation that you use, how easy is it to use that information to can you stimulate in the same way outside the scanner, would you expect, and get the same kind of effect? Or are the means that you have to use to actually use the electrical stimulation in the scanner, does that sort of change the system enough so that you couldn't easily replicate it outside the scanner? Does that make sense?
We can almost use the identical system that we can use outside the scanner.
Okay.
Inside the scanner.
Okay.
So that is
the parameters that you optimize inside are likely to work outside as well?
Absolutely.
Okay.
Absolutely.
No.
So that is exactly the case in terms of if we can't find the right way to do it. I'm still not sure that we can find the right way to do it, but there is a big if, but if we can find the right way to do it, that might be helpful for outside. Even if we have an idea in terms of what is the level of variation among the subjects in terms of the optimum parameters, I'm still not sure about. Of course, that's a $1 million question. That is, if we can even find the variations. And of course, there
might
are
be more than a million. Might be more than 1 million.
Of course, yeah. Just a kind of a old way of expressing that. We probably need to go for billion right now. But technically, there are definitely lots of technical challenges. I definitely would be happy to give something like 1 hour or more, something like a full day workshop discussing about the technical challenges that we are already facing. One really simple thing is the frontoparietal, whatever kind of connectivity measure that we have in fMRI is fluctuating. So it is not a kind of constant target. We are thinking about something that is already, it has a level of noise inside, or it has a level of signal in terms of the fluctuation. And you are trying to kind of go for a moving target and trying to kind of make a significant change on that moving target in a way that could be recorded. And then there is always a question. For example, what I'm doing right now, I have some slides for that at the end, so we can kind of go for those details. But what I'm doing, I do something like 20 seconds of stimulation, 20 seconds of stimulation, and I start to record fMRI with 6 seconds delay of that to be able to kind of go for the hemodynamic response delay that we have. And then I have something like 10 minutes of rest between blocks, and I need to do the online fMRI processing. That what we are doing right now. We can collect fMRI data, do pre-processing, post-processing, everything in 400 milliseconds right now. And then we use that data to loop into the kind of the stimulation again and start the next trial in terms of the stimulation. So we do multiple trials of recording, stimulating, and there is an optimization protocol that right now we are using simplex, but there are, we have experts in the field right now, people like Alec, he's doing lots of different cool stuff with that, but different optimization protocol could be could be in place, and we can discuss about what would be the best kind of optimization protocol in terms of the computational time and the other things. But that is another, I mean, there are many other issues regarding that, but just kind of giving you an idea. I have kind of just a few other slides to just kind of wrap up this part. Yeah.
I want to ask, there's a really important issue that this kind of an optimization assumes, which is that there's no history here, that each trial is independent enough to optimize. Do you know whether that's true or not? That is there, if you stimulate at one frequency for 20 seconds, does that going to change the next time you do it, or can you treat each one as independent?
I mean, there are definitely lots of important questions. Probably the major ones would be, first of all, we have no idea about the temporal dynamics of response to what we are doing. So that is the first major question. For example, for fMRI, we have HRF. So we know that, okay, if we do a stimulation, that would be the temporal function of response that we will have. And we know we have people who work on that, so we have an idea about that. We still do not have a clear idea about what is the temporal function of response to the stimulation. So that is the first issue that we would be facing. The other issue would be, okay, what we did the optimum way of doing the stimulation, and then based on the stimulation, optimizing the next round of stimulation. Should we go for 20 seconds? Should we go for 1 minute? What is the kind of the optimum duration? So there are many questions regarding the temporal aspect of what we are doing. So we have just started to dig into the first small piece of what we are able to do, and we are still in the kind of in the steps of being able to see that is there any effect of what we are doing, and can we make any meaningful change in a direction that we are expecting or not? So we are still in this step. There are definitely many. I mean, if we can, the good thing, it seems so far, based on my experience, it is technically feasible. That is, I'm quite sure that it's technically feasible. But what is gonna be kind of the result? I have no idea. I'm still. I have a PhD student in OU, Oklahoma University, and they have every Friday I have meetings with. We have already collected 20 subjects. And we have started to kind of test the initial things that we are doing. It seems that there is a trend, so we are working on. So we are working on that. But I'm hopeful to be able to make that happen here. So let me just go for a few other slides. That would be my last slide. So just showing you one of some basic things that we have started to do. One of the first things that we have been trying to do is just to see how we can make that happen. So we started with stimulating watermelons and making specific electrodes for watermelons, and of course, kind of putting multiple electrodes in different watermelons and using EEG cap to just kind of doing different versions of a stimulation. And of course, you can see inside the watermelon whether the watermelon is ripe or not, or is ready to eat. But based on that, we realized that we can control the noise. So it seems that technically, and watermelon has a kind of interesting kind of features in terms of we can do the stimulation on watermelon, and there are interesting things about it. So we have collected data on that, and of course we eat watermelon after the stimulation. So that is the routine that we do every session that we do the stimulation. And of course, after watermelon, the next subject would be PI, to go inside the scanner and do the stimulation on his brain. And Ashkan is one of my kind of research assistants, so we kind of put those pieces together. And after PI would be kind of the next people that they go inside and do the stimulation. But I have some personal experiences with the stimulation inside the scanner for something like 1 hour, and I can tell you some of those stories, but we do not have time for those details. But kind of there are some technical details right now. I have a PhD, Benny, and postdoc Aki. We have been working on that. They are wonderful in terms of making that happen. I'm right now working with Mo Chen. We have been talking to Dr. Chen in technical details. We are exchanging tens of emails during the last couple of days, just going through the technical details of how that could be happening. We have been discussing with Brian Muller. We have been kind of exchanging lots of emails to see how we can make that happen. I put together a bioarchive report that is available right now. I put whatever I knew so far about that in terms of the technical details, the montages, the the noise, the testing that people can do inside that bioarchive report, so people can go and see whatever we have done so far and the design that we made. That would be helpful for those who are interested to do. I don't know any lab that is doing the same thing, because what we are doing right now is network level, high definition, frontoparietal synchronization with alternating current inside the scanner, which is, to my experience, is unique. But we definitely need lots of kind of supports. We are even kind of doing some technical scanning. We do not have, I mean, we are still discussing with Dr. Lynn Kelvin. We are discussing about how to bring money for that. So we are working on that to see how we can bring resources for that. But if people are interested to kind of collaborate and help us for that, definitely there are many potentials for that. And I'm going to be focused to drug addiction, because that is what I've been doing during last kind of couple of years. I'm not going to go for other things, but if people are interested to kind of use this setting for other questions, and I'm going to be more focused to kind of met use disorder and stimulants, but people are, if they are interested to explore it in other areas, I would definitely be happy to help them, and kind of we can develop different versions of what we are doing. So that is another line of things that we are doing. So I'm hopeful to be able to, first of all, extend the measures that we are developing with drug cure activity, make sure they are reliable, they are valid. So that is the main thing I'm trying to extend. The second, I'm trying to develop cognitive interventions that are going to engage those networks, and also non-invasive brain stimulation technologies that would be engaging those networks. So this is my main plan for the next 10 years, hopefully, to get them done. And thank you for your attention.
Thank you, Hamed. That was a really interesting presentation. Please, anyone who's has a question or comment, go ahead and unmute yourself and jump in. I especially encourage any trainees to jump in with their questions or comments.
I've got one. This is Scott Burwell. Great talk, Hamed. It's very impressive. We've talked before, but very impressive research program, and highly related to stuff that we're projects that we're working on in psychiatry at Justin Anchor. And one question I had about, and I probably should have asked it earlier, regarding the CRIF, the reconsolidation model or therapeutic model, is the control images. And we're working with that image set for, cue reactivity in patients right now. But the control images, if part of the goal is to sort of reshape somebody's memory, let's say the spoon, for example, that somebody is pre-associated with, cooking drug, over a flame or something with, and you want them to reshape that memory towards a spoon focused around a family and a meal or something like that, right? Would you need to adapt the cues such that, the control cues would be more related to this new memory that you're trying to generate? Is that a concern that has been raised yet?
Yeah, that's an important question. I'm really happy that you read the paper in details. That is amazing. That's exactly the discussion that I had with kind of with the team that we have been reading, kind of writing those pieces. The spoon in the figure, that is not the part of what we are doing, because that is probably a good example of something that is not a good cue to modulate for the package that we have, because of its kind of application in other contexts. It's really hard. But the reason that, we ended up kind of putting a spoon inside, because it was easier to kind of to visualize in the figure. I need to send you the new versions of the figure that we are developing in terms of not going for those types of cues. And the reshape that we are doing is not reshaping in terms of kind of having spoon as a way to cook heroin, compared to a spoon as we're using that in the kind of a family gathering. That is not the way that we are thinking about that. That is kind of more towards the different contexts that the drug cues would provide. For example, the ways that people are using, or the scenarios that they are exposed to, kind of a group of people that they are using, and trying to reshape those specific contexts. And in this context, it's different in compared to control cues. Yeah, that's a good catch.
So I have a trainee question. I'm a third-year PhD student in the Spencer Lab, and I'm working with the cue reinstatement rat model. And I'm also interested in TMS, and I'm just kind of wondering if you can talk about connecting preclinical data to clinical data and how to help having that scientific conversation.
One of the things that might be interesting in terms of the TMS, for example, the deep TMS machine that is going to receive FDA approval for OCD. One of the things that they are doing, a part of the FDA approval, it should be associated with specific behavioral intervention that is inducing some specific kind of OCD scenarios or kind of situations. So it is not just the package that there is a kind of associated behavioral package is a short, and the combination received the approval. And it's quite amazing in terms of how you need to engage those networks to be able to modulate them. And that is a kind of an understanding in the field that if you want to make your stimulation more effective, whether it is TMS or TES, they are supposed to, I mean, it would be a better idea to engage those networks first and then stimulate those networks. That would be, and there are specific computational models in terms of when you have an area of the brain which is more activated, then that specific area would be more influenced by the stimulation that you are doing. And that's the kind of a motivation for combining the behavioral paradigms with the stimulation. And I think that's an interesting potential. Even for the drug addiction trial with that kind of deep TMS machine, the idea that they have for the design of the trial, they are still discussing in terms of the opioid trial. I'm not sure what is the final decision because they received a fund from NIDA to run a large trial with opioid use disorder. But even for that, the idea was using the drug cues for that in terms of activating those things. In terms of how we might be able to modulate in a certain direction with neuromodulation stuff that we are doing, sometimes even if we disrupt a specific process, sometimes disruption is easier to make things better. So that is my understanding about kind of the brain stimulation. And sometimes I'm thinking that, okay, if we can just disrupt something that is happening, which is not what we are interested to, that might be a potential for kind of making the effect that we are expecting. So it's not always kind of thinking about enhancing a specific function or making things better, because it's really hard to make things better in the brain. So it is because it's already doing its best way to process different information. But we probably can disrupt things in a more efficient way. So if there is a chance that we can disrupt some of these processes that are involved in these kind of memory consolidation or memory shaping or even changing those things, that could be a potential. There are studies in terms of even for specific frequencies in terms of going for what we know what is happening during sleep. So in terms of if we can change memory consolidation during sleep with a specific frequency. So there are studies on that direction as well in terms of changing memory consolidation based on kind of some frequencies. But I'm not quite sure that we are still there in terms of making things in the direction that we are expecting.
Thank you.
Probably have time for one more comment or question.
And I have a quick question from Alec right now in the chat as I'm trying to kind of read the questions that, I mean, I think I basically kind of address some of the questions that Alec has already kind of raised here in terms of how long does it take to see if you have the reasonable signal. I mean, I'm not quite sure about that, but that is the reason I was thinking that the kind of UH3 mechanism might be a good idea for that, because that would give us something like 2 years of time to be able to see if we have a yes or no, or go or no go kind of decision at the end, if we can engage the networks or we cannot. So we are still, to be honest, in that stage of go, no go, if we can engage or not, and then thinking about, okay, how we can optimize that. So we are still kind of at that level of discussion.
Well, thanks everybody for coming. I want to say one more thing before we end. Well, first, thank you to Hamed for a really engaging presentation and a good discussion from everyone. We need speakers for the next 2 months. We have one for each. So if you have a trainee or if you yourself are interested in speaking, please let Carrie know. Don't be intimidated by the intensity of today's presentation. We have, you know, undergraduates who are doing their first scientific presentation here sometimes, and we obviously have a very experienced speaker today. So please, if you're interested, sign up with Carrie and we'll get you on the docket, and we look forward to seeing you all next month. I hope many of you before then. Take care. Have a good afternoon.
Thank you. Bye-bye.